Hello everyone and welcome to Visu online training, where we help you step into success. Today, we are diving into one of the most critical chapters of ICD 10cm coding, Chapter 2, which covers neoplasms within the code range C00 to D49. We will explore how these codes are structured, starting from malignant neoplasms in the C range to various types of benign and uncertain behaviors in the D range. Understanding this classification is the foundation for accurate medical coding in oncology. To begin, let us define what a neoplasm actually is. The word literally means new growth. In medical terms, it refers to an abnormal mass of tissue that results when cells proliferate or multiply in an uncontrolled manner. This growth doesn't serve any physiological purpose and can be classified into 5 distinct categories: malignant, benign, in situ, uncertain, or unspecified behavior. We will discuss each of these in detail as we move forward. In the world of oncology, we generally distinguish between solid and liquid cancers. Solid cancers are those that form a physical mass or tumor in organs, such as breast cancer. Liquid cancers, on the other hand, are hematologic malignancies. These don't form a single lump but instead affect the blood, bone marrow, and the lymphatic system, a classic example being chronic lymphocytic leukemia or CLL. When it comes to coding, the ICD-10 manual breaks neoplasms down into specific categories based on their behavior. We have malignant, which is further split into primary and secondary, carcinoma in situ, which is localized cancer, benign or non-cancerous growths, and then to specific gray areas known as uncertain and unspecified behavior. Let's look at what each of these terms implies for a coder. Starting with benign neoplasms, these are essentially non-invasive growths. They do not spread or metastasize to other parts of the body. While they are not cancerous in the aggressive sense, they can still cause health issues by compressing nearby organs or tissues. For instance, code D24.1 would be used for a benign growth found in the right breast. Malignant neoplasms are what we commonly refer to as cancer. These are invasive and have the potential to spread to distant sites. When coding, the general rule is to code the primary site, where the cancer started, first, unless specific guidelines tell us otherwise. For example, if a patient has colon cancer but the specific subsite isn't mentioned, we use code C18.9. Sometimes, even after a biopsy, the pathologist cannot definitively say whether a tumor is benign or malignant. In these cases, it is classified as a neoplasm of uncertain behavior. This is a specific clinical determination. An example of this would be code D48.5, used when the behavior of a skin neoplasm cannot be clearly established by the lab. You might wonder how unspecified behavior differs from uncertain. Unspecified is used when the documentation in the medical record simply doesn't provide enough information, or perhaps the pathology report isn't available yet. If a doctor just writes bone neoplasm without further detail, we use code D49.2. Carcinoma in situ represents a very early stage of cancer. The term in situ means in its original place. These cells are cancerous, but they are still confined to the epithelium and haven't broken through the basement membrane to invade deeper tissues. A common example is intraductal carcinoma in situ of the breast, coded as D05.11. It is vital to distinguish between primary and secondary sites. The primary site is where the cancer originated, like the breast. The secondary site is where the cancer has spread or metastasized, such as the liver. As a rule, we continue to code the primary malignancy as long as it is being treated or is still present in the body. To determine the direction of the cancer, look closely at the physician's wording. If the notes say cancer to the liver is secondary. If they say cancer from the colon is the primary source. Always double-check the pathology reports and the physician's final documentation to ensure you are capturing the correct sequence. Sometimes a single tumor grows so large that it overlaps 2 or more contiguous or adjacent sites. If the documentation doesn't specify which site is the point of origin, we use the point 8 subcategory for overlapping sites. For instance, C16.8 is used for a lesion that spans across different parts of the stomach. In cases of widespread metastasis where the cancer is found throughout the body, we call it a disseminated neoplasm. We code the primary site followed by multiple secondary codes. However, if the primary site is completely unknown, we use the specific code C80.0 for disseminated malignant neoplasm. Cancer patients often suffer from complications like anemia. If a patient is admitted specifically for anemia due to malignancy, there is a very specific sequencing rule. The anemia code D63.0 must be sequenced first, followed by the code for the cancer itself. This is a key guideline to remember for your exams and daily work. Pancytopenia is a more severe condition where there is a deficiency of all three components of the blood. Sequencing here depends on the focus of the treatment during that specific encounter. If the doctors are primarily treating the pancytopenia, code D61.818 first. If the focus remains on treating the cancer, then the malignancy code takes precedence. Dehydration is another common complication. Similar to pancytopenia, the sequencing depends on the reason for the admission. If the patient is admitted solely to receive 4 fluids for dehydration, 86.0 is your primary code. If they are there for cancer treatment and happen to be dehydrated, the cancer code is primary. Bowel obstruction can often occur with gastrointestinal cancers. Again, the focus of treatment rule applies here. If the surgeon is performing a procedure specifically to clear the obstruction, code K56.609 first. If the encounter is focused on treating the underlying cancer, then the malignancy code is sequenced first. Once a malignancy has been fully excised, the treatment is completed, and there is no evidence of remaining cancer, we no longer use the C codes. Instead, we use a history of code from the Z85 category. For example, if a patient had breast cancer 5 years ago and is now clear, we use Z85.3. It is important to know when a cancer is still considered active. As long as the patient is receiving treatment, whether it's surgery, chemotherapy, radiation, or newer therapies like immunotherapy and targeted therapy, the cancer is coded as an active malignancy using the primary site code, not a history code. Finally, let's look at how neoplasms are diagnosed. While CT and MRI scans provide great images, a biopsy remains the gold standard for diagnosis. Other methods include FNAC or core biopsies, PET scans for metastasis, and blood tests for tumor markers. For liquid cancers, a bone marrow biopsy is the essential diagnostic tool. Understanding these methods helps you interpret medical records more effectively. Thank you for joining this session.